next speaker is my colleague and friend, Dr. Aaron Clark. Also probably the best surfer amongst the attendees here. He's going to give us a talk on lateral interbody fixation.
Well, thank you again, everybody. I think every year I'm anxiously hoping for an invitation to come back to this talk. So thank you guys for having me again. I really appreciate it. I really like the order of talks today. I think this is going to build really well on what my new partner Nima spoke about earlier. And these are my disclosures, not really relevant to this. I kind of like to think of myself as an unofficial surf historian of this conference. And so I just wanted to talk a little bit about this. I try to every year, and also maybe give a little bit of context to the some of the displays you see in the lobby. So this is actually the first known picture of surfing ever taken. By this final day of the conference, I hope this view is very familiar to everybody. You can see Diamond Head in the background. So this is taken right where we're sitting, basically. And I think I want to reinforce this every year, what a special location this is for all the surfers out there. So thank you guys again for this location. I also want people to focus on the design of the surfboard. This is basically a solid plank of wood. And compare that to this picture, which is me from a couple months ago in Nicaragua, and look at what a change in surfboard design has happened in this 100 years or so. And how did we get here? I think there are a lot of parallels with spinal instrumentation and spinal research. It's a little bit outside the scope of this little sidebar to talk about how we got from there to here, but it's gone through multiple iterations. Just sort of a broad view of it. Dating back to near ancient times, the first design was what's called an aliyah, which this ancient Polynesian is holding. It's solid wood, Hawaiian wood. It's handcrafted, made from koa wood. And this really stayed the same until about the 1900s, when people started using more readily available balsa wood, but it was from South America, and weighed about 100 pounds. So imagine lugging that to the beach. The big change was the advent of polyurethane. This is in the 50s, dropped the weight from 100 pounds to 10 pounds, and also allowed the addition of fins, which gave you more control when surfing, significantly cheaper and easy to shape. And then initially the advent of the shortboard, which a lot of us ride now, in the 70s, took about 3 feet off the surfboards, lighter, allow you to do much more aggressive maneuvers on the wave, like this picture here. That's not me. And then more recently, and I think this does also apply to things going on in spine right now, is the advent of computer shaping in the 90s. So increased reproducibility, which is something we talk about a lot, significantly expediting the design process, the ability to mass produce reproducible surfboards that can be a little bit fine-tuned by hand, but there's this concept of losing the individualization, losing a little bit of the soul of the process. And I think it's something that we're also seeing in spine surgery as well. I know that our course directors had a little bit of concerns of changing the venue from the historic Royal Hawaiian, but I think from a surfer's perspective, as you can see from this vintage poster of this hotel, this is still a really special surf hotel. So thanks again, guys. Switching gears to a little bit of more relevant history, I'm going to be talking about anterior and lateral approaches, particularly minimally invasive approaches. And the history of this dates back to the early 1900s, when Mueller described the first transperitoneal anterior approach to the lumbar spine to treat TB. In the late 20s, Royal described a retroperitoneal approach to a congenital hemivertebra, and a little bit later there was a retroperitoneal anterior osteotomy described by Chaklin. In the 30s, Burns, in his seminal paper, described the first actual fusion from an anterior approach for spondylolisthesis, and this is what it looked like from the original paper. In the 40s, Iwahara described a retroperitoneal approach anteriorly to do an ALIF for degenerative disc disease, and the famous paper by Lane and Moore used a transperitoneal approach to do an ALIF for degenerative disc disease as well. In the late 90s, with the advent of threaded cages, really moved in more modern interbody instrumentation for fusion. The advantages of ALIF, I use this a lot in my practice, is there's no neural retraction and improved ability to restore lordosis, disc height, and foraminal height when you're coming from an anterior approach compared to a posterior approach. And this is just a quick radiographic demonstration of that with the ability to really restore disc height, get a nice big lordotic cage into the L5-S1 space. And this is particularly important when thinking about treating L4 to S1. We know that we really want to get about 2/3 of our lumbar lordosis from these segments, and being able to treat that anteriorly can be really critical, particularly in a patient like this, one of my patients that has a relatively high pelvic incidence. So you really want to be able to get a nice lordotic implant to build the base for this. Ultimately, need an L5 PSO to correct the deformity. But the L5-S1 ALIF with a hyperlordotic cage really gets a good harmonious correction through that segment, as demonstrated here. So before moving into some of the lateral approaches to the L5-S1 space, I want to talk a little bit about how we got there. And part of this has to do with risk stratification for ALIF, particularly when thinking about obesity. And this is a paper that I was involved in a few years ago, looking at some risk factors for ALIF. We did a retrospective review of about 1,000 cases and stratify these patients based on their obesity status and collected some surgical details. The complications we designated were what you'd expect based on the anatomy in this area, so vascular, bowel, ureter, etc. And what we found is we did actually have a high percentage of obese patients in our data set, fairly complex problems being treated with ALIF. And we did have a fairly high complication rate at a tertiary referral center, primarily driven by postoperative complications. We did have long follow-up. The older the patients were, the higher their BMI, so obese patients were all associated with increased complications, as well as increasing complexity of the problem that's being treated, for example, deformity or infection. And what we found was most of the complications were postoperative, so ileus and wound healing complications were the most significant issues here. And if we stratified patients based on the severity of their obesity, there was a trend towards more hematomas and more DVTs in these patients. We then did multivariate analysis and found that obesity was an independent risk factor for complications. And in sequentially looking through different BMIs, we found a threshold or a cutoff at a BMI of 31 where your complications kind of skyrocketed once you got over that body mass index. And so we did find that BMI threshold greater than 31, mostly postoperative complications, and basically take-home point from here is these patients need to be treated with surgery, but they should be significantly counseled on that elevated risk of having some sort of problem. Pay very close attention to wound healing, and also consider lateral positioning. And that can often help treating these obese patients who need an ALIF. We know, borrowing from some of the lateral interbody fusion data, that lateral surgery is very safe, very low complication rate. It has good outcomes with improvement in HRQOLs. And when thinking about sagittal alignment, it can improve lordosis, and it can even improve global sagittal balance, has been shown here. But the benefit to the obese patient, I think, can be demonstrated in this patient of mine, where you can see in the lateral position that the abdomen will really shift away from you and limits the amount of traction that needs to be placed. A little bit about how this is done at L5-S1. The incision is planned with fluoroscopy. The first line that's drawn is a line coaxial with the L5-S1 disc space, and the second line is a vertical from the midpoint of the L5-S1 disc space. And that describes a triangle, and your incision you want to make within this triangle. You get no benefit from going higher than that because it won't get you to the disc space. And what we found is that making the incision about 3 finger breadths in front of the ASIS puts you right exactly where you want to be. It's a nice balance of being medial enough to do your ALIF, but lateral enough so that you can get into a nice retroperitoneal plane. The nice part about it from a wound healing perspective is it's a true muscle splitting, so a minimally invasive solution here, which possibly leads to less hernia and possibly less pseudo hernia because the nerves really aren't at risk here. From an ileus perspective, it gives you a nice wide exposure to the disc space, but again, because gravity is pulling that abdomen and the abdominal contents anteriorly, there's less peritoneal retraction. And it still gives you, again, really good midline access to the disc space, and you're doing a true ALIF once you get down there from the lateral approach. So shifting gears a little bit to lateral interbody fusion, I think we talk a lot about sagittal alignment, but I think it's important to think about coronal alignment as well. In what the ISSG had shown here is that if there is a residual coronal malalignment, that is associated with worse outcomes. So really need to think about that, especially when you're doing lateral surgery. It's important to think about classification systems for coronal imbalance. This is there are several, but this is the BOW classification that typically used in my practice, having to do with how the trunk is shifted relative to the apex of the major curve. And of these three types, the type C is the one that's more difficult to correct because your trunk is actually shifted in the direction of the apex of the curve. And in this paper, at least about 60% of these patients had persistent malalignment after surgery. My partner, who we just heard from, Alekos Theologis, wrote a really nice paper when he was a fellow taking a bit of a deeper dive into this, looking at the WashU data. And in their 124 patients, they found that similarly, if a patient started as a type C, they ended up, about 2/3 of them ended up still malaligned. And in taking a deep dive into this, they found that this had a lot to do with undercorrection of the lumbosacral fractional curve, as you can see in this table here. So looking a little bit more into the role of interbody fusion, lateral interbody fusion in adult scoliosis, you can see that in stage procedures after the lateral approach, you get significant improvement in a lot of our spinal pelvic parameters. And after you dial that in with the posterior operation, you get even better. In comparing different groups, posterior only to posterior lateral and posterior anterior lateral, you see improvements in PJK after these operations, and that's potentially related to decreased fracture at the UIV. And significant improvements in pain, and particularly in the lateral when you add lateral to these operations. So it is a big part of my practice. Now, it does come with a cost. There is an increased OR time, as you can imagine, with a whole separate stage to do lateral, and then increased hospital length of stay, which makes a lot of sense particularly if you're doing it in a planned staged fashion. So here's a patient of ours, again, based on Nima's talk, we use a 2-surgeon model, so I do all of these complex operations with Alekos Theologis. This is a patient with a type B curve that does have some rigidity to it, as you can see in this CT scan, and some of the spinal pelvic parameters from the EOS. It's this operation I started with a lateral ALIF at L5S1. Sorry for the radio opaque bar in the way here, but I was happy with the placement of a hyperlordotic cage, and followed that up with a lateral interbody fusion. And I think this video can demonstrate some of the power of doing the lateral approach, including breaking that lateral osteophyte up at L1-2 in placement of lordotic lateral cages to at least begin the sagittal and the coronal correction. And this is our intraoperative long plate, which is got from the O-arm, that matches well with the correction that was obtained when the patient was ultimately able to stand postoperatively. Preoperative and postoperative. So advantages of lateral, it's improved surface area for fusion. It allows you, as we demonstrated in that last case, to release the contralateral annulus and osteophyte, and also you can restore foraminal height and provide indirect decompression with an interbody device. This is a type C curve, so I want to illustrate that same point. These are difficult to correct. Also had some rigidity there. This is a patient where I did similarly a lateral interbody fusions. And as demonstrated in these papers that I presented, this patient, although it's a fairly mild type C curve, the patient was persistent type C curve after that, and potentially related to those interbody cages that didn't allow that perfect correction, the lumbosacral fractional curve. And this has been shown by Juan Uribe in Arizona that when doing lateral, minimally invasive lateral interbody fusions, if they start at type C, a lot of these patients are remaining malaligned after using interbody cages. What we've started to do to try to address this problem is in people that have the type C curves, still doing the lateral minimally invasive approaches and doing the release of those osteophytes that are holding them in that fixed malaligned position. But instead of placing a cage, we'll just release the osteophytes, place bone graft, and that'll allow us to do more fine tuning of the curve without having that problem of the cage fixing you in that malaligned position. And this is a patient where had a type C curves, and we did our minimally invasive lateral releases and ALIF at the bottom, and very happy with her correction afterwards. So in general, when thinking about lateral interbody fusion for deformity, type C curves are at risk of undercorrection. The addition of lateral interbody fusion can be beneficial both coronally and sagittally, but it may not adequately correct these type Cs. So one thing to consider, and I know Kyle Mitsunaga and his group here use this technique also, is consider minimally invasive releases without placing the cage to help you dial in that correction. Certainly need additional research in this arena. Well, thank you very much. Again, this is a really special meeting for me. It was the initial trip that I took with my daughter. This was her back in 2001, 2022, and this one from yesterday. What's the future going to hold? Hopefully some of this. Thank you, guys. Happy to take any questions.
Aaron, that's a great talk and great overview of surfing history. I learned a lot. Sure. In your practice, the traditional supine ALIF versus now lateral ALIF, how did you completely switch over, or do you see like improvement in speed overall? What are some of the disadvantages, doing ALIF in lateral?
Yeah, I think that's a great question, Lee. I was a pretty early adopter of the lateral ALIF. To me, lateral from 1 to 5 had already been a big part of my practice, but I was a little bit resistant to it for deformity because either I had to do 3-stage surgery where I did a supine ALIF, then I did a lateral operation, then I did a posterior operation, or I do something like a T-lift down at L5S1, and I think we know the potential disadvantage of that. So this turned what would typically be a 3-stage surgery for me into a 2-stage operation. There certainly was a learning curve, and there are even more nuances. I'd be happy to talk to anybody interested in about it, but really being able to get that cage into a nice midline position can be tricky. So I think the disadvantages come from the learning curve. I think the inability to do an ALIF at 4.5 for people that don't feel comfortable doing a direct lateral at 4.5 is another disadvantage.
Do you do the laterals first or ALIF first?
So I always do the ALIF first. You can potentially do it in any direction. We learned the hard way though. My vascular surgeon that does the approach for 5.1, he wants the patient completely paralyzed for that operation. And so if you do the lateral first and you have to reverse the paralytics to be able to do your EMG to do the direct transpose approach, the reversal agents for the paralytics cannot then be re-reversed to paralyze them again. And so it's critical to to paralyze a patient, do your ALIF, then you can reverse them and do your laterals. If you do it in the opposite direction and they're still paralyzed by the time you're ready to do L4-5, then you just have to sit around and wait for that to wear off.
Aaron, for cases where L4-5 doesn't have favorable anatomy for a direct lateral, are you doing supine ALIF and then staging a lateral, or what's
Yeah,
your approach?
that's what I would do in that situation. It's nice to know that ahead of time. If the crest looks really high or they clearly have transitional anatomy, you just plan for that. I push it a little bit. I'm pretty comfortable with doing 4-5, and so using angled instruments. And I've recently switched to a 2-blade retractor for my laterals, and that allows you even a little bit more freedom to move your hand craniocaudal. But there are definitely going to be situations just like that.
Great talk. Your evolution of your technique is really impressive, especially what you're doing at 5-1. You pointed out that the type C curve, that bow C curve, can be challenging with the lateral, and the real problem is overcorrecting that thoracolumbar curve, and that fractional curve is so challenging to fix. Do you think that those type of cases might be better off with an ALIF from 4-1 because you're getting the concavity from 4-1 corrected? Do you think you can really do that well with an NSOS approach to 4-1, or you think you're better off with patient supine and really getting the cages on a concavity?
Yeah, I think it's a really good question. Since I've started noticing this problem, because I want to preserve the advantages of being able to do a single stage L1 to S1, I'll still try to do that direct lateral, but I generally am not going to try to overstuff that disc space with a big giant cage. And I think at least what our experience has been so far is that allows us a little bit more ability to fine tune it from the back. Thank you.